Good morning and welcome to day 2 or day 2.5 of the 10th Annual International Coronary Congress. In keeping with our firm belief in the heart team approach to the management of coronary artery disease, we have created another plenary session this morning to have world-renowned cardiologists educate us, coronary surgeons, on some of the things that they do that are truly remarkable and which are not front and center in our thinking and perhaps not in our knowledge base. So we're looking to learn this morning about the imaging that is changing the world of coronary care and how it will impact coronary surgical care. Once again, we're honored to have Patrick Sirois, an extraordinary contributor to the field of interventional cardiology and coronary imaging, give our opening address at this morning's plenary session. I know that there will be some people coming from the room next door where their abstract session this morning was well attended and running a little late, but we do need to get started, and I invite Dr. Sirois to the podium to discuss with us coronary CT angiography and coronary CT FFR. How this will impact diagnostic coronary angiography and coronary care in general. Professor Sirois.
Good morning, everybody. So the undertitle is Coronary Angiography Going to Disappear. That's also a title proposed by John. So in 2040, why 2040? Because at the ESC I had to talk on that. That was the topic imposed. And I say that conventional invasive coronary angiography as a diagnostic tool of CAD will have left the scene at that time. But today, how do we do the triage of the CAD patient? Personally, I work more and more with AI, remote anamnesis. Then I have the pretest probability recommended by the European Society of Cardiology. And then I use multi-CT for assessment of luminogram, vessel wall composition, and hemodynamic. That's what I described as the one-stop shop a couple of years ago. So you see the CT angiography for stenosis detection. You see the ejection fraction. You see the wall motion. You have the fractional flow ratio. I do, for my pleasure, some hologram for John Puskas, so we know the length of the bypass that he has to harvest. And then you have now the microvascular circulation and the myocardium at risk, which is called the LV% myo, which will be commercially available this year. Then on the conventional CT, this is one cross-section. You can have the lipid-rich area, the fibrofatty area, the calcium, the fibrous area, and the lumen. And with the photo counting, I'm discovering really new phenotype of plaque. That's what we call the donut plaque. This is calcium surrounding low attenuation. You could see that on histology it corresponds to deep calcium and superficial calcium with necrotic core in between. I almost forgot that today we can look at inflamed perivascular fat, very, very important. And then, at least in my place, the clinicians start to use machine learning and their smartphone to predict the MACE and death. You have seen that yesterday. So this is Heart Team new style in Galway. We are around the table. The surgeon is seeing through the goggles the heart we see on the screen, and he's explaining what he's going to do with that heart. It's extremely powerful instrument. And then at the bottom, you could see I'm measuring the length of the bypass that John will have to use in this case. That's basically what I see through my goggles. And I see you, I see in the operative room my hands and everything, but I have in front of me this type of image. So when you have done that, you can move directly to the cath lab with a carefully planned coronary intervention based on pre-existing information, or, like we have done with John, move directly to the operative room without cine angiography. So this is a case that we did, and I say that the state of the heart in 2024 will be routine at that time. So this is a case that we do a live case at EuroPCR from Toulouse with Bruno Farah. As you could see, we measure the sinus, and then we know that we have to take a guiding catheter with a band 3. When you see the calcium, immediately we use lithotripsy to break the calcium before putting the stent. I know in which projection I have to approach the main stem, LAO 20 degrees, cranial 30, and I know in which projection I see this bifurcation, calcified bifurcation. And on top of that, we have virtual treatment. If I put a stent of 3 mm, 28 mm with a proximal 4.5, I will normalize what was in red. The only thing that remains ischemic here is a secondary branch of the first diagonal. Now, the same is true for the surgeon. What you see is first the MIP, but we do much more than that. Here you could see the MIP, the volume rendering, the FFRCT, and the multiplanar, and we have an anatomic syntax score of 58.5. We did that every Thursday across the Atlantic and across many places in Europe for this trial called a fast-track CABG. So that's the paper published with John and Yagat Narula. 111 patients were operated without cine angiographies with a feasibility of 99.1%. Patency of all the anastomosis was 92.6, and the agreement with the conventional angiography was 82.9. I can tell you in 2040, conventional coronary angiography prior to CABG will no longer be performed. With the sole guidance of new generation of CCTA, decision-making in favor of surgery, PCI, or pharma will be made routinely by the heart team. CCTA as a game changer may change the gatekeeper. Pay attention to that. The game changer may change the gatekeeper of the mechanical revascularization. This is the type of case that John did in the context of this trial. I mentioned that yesterday, all off pump. But not everybody can make 5 arterial anastomoses. So we have been working on a biorestorative graft. We have published that in JACC Translational. I hope that at some point, graft made of electrospun fibrillate microfiber of biodegradable supramolecule will be available on the shelf in the operative room and will expand the revascularization capability of the surgeon. You see the matrix of microfiber of supramolecule. You have the process of degradation. We have done multiple animals. You could see here with a sequence of anatomopathology from day 0 to 12. We have multi-slide CT scan. You could see the graft going from the aorta to the LED, which is ligated. And Renu Vimani has found, and that's quite unique, that there is in scanning electron microscopy endothelial cell also in transmission, and they are von Willebrand positive. That's very good. Now, what is a dream, as a matter of fact, is already a reality, because that's the first in man. As you could see, the right coronary artery is totally occluded. The bypass graft made of this material with this reinforced nitinol ring, and I'm sure that David will be interested by that, goes to that trifurcation between the right coronary artery, the posterolateral, and the PD. Now, the next tsunami in cardiology is on the horizon. With photocounting scanner installed in more than 300 hospitals around the world, you will not stop that. and I'm very, very impressed by the image that we receive. Conventional system, the X-ray photon has to go to two levels, a scintillator and a light sensor, to be converted in an electrical signal. But with the photo counting, it's a direct conversion to the electrical signal with only semiconductors. Now let's see some image. This is a conventional CT. That's already pretty good. But look at the blooming effect of the calcium, and you see this small region of low attenuation, visible but not too sharp. You can use post-processing like high-resolution CT. You see that the blooming effect is less, but the low attenuation has disappeared. You must realize that this individual has been in 2 multi-slide CT scan. Now look at the image of the photo counting. The calcium is now very sharp, and also the region of low attenuation. Both are very sharp. Photo counting scanner can clearly visualize stents, struts by struts with a resolution of 111 micron. This is today, that's already the past. Then CT can visualize the struts with a resolution and allow a 3D reconstruction that you see here of two stents, and you could see the metallic carina at that level. Clear delineation, very easy, and quantification, very easy. So easy quantification also of diameter stenosis. I don't need an angiography, this is better. That was a surprise of John to say, this is better than the angiography made downtown. That's what you said. Now look at total occlusion. Total occlusion, this lesion here, you could look at the proximal cap. You could look at the very low attenuation, thrombotic probably. You could see the region of low attenuation, and you can see the distal cap. I don't know if Bill is still in the audience, but if he's still in the audience, I would say this is a piece of cake for recanalization. Then CT photocounting can identify complex calcified plaque morphology even better than intravascular imaging. Look at this cross-section here, shows a positive remodeling. You have some calcium endoluminal, you have deep calcium, and that's what I've never seen before. There is a connection between both. You do an IVUS, the IVUS with the shadowing of the calcium, and you are blind for which is behind. This is the donut, as I call it. As you could see, you have low attenuation surrounded by calcium. I didn't know that it was existing, you know, because when I do an IVUS, I'm blind behind, and when I do an IVUS with near spectroscopy, I know that there is fat there, but I don't know the depth. And look at the histology, you see the superficial calcium, the deep calcium, and the necrotic core. I'm finishing on this. It's new. That's the HIP CT, hierarchical phase contrast tomography. One of our collaborators here in London, Hio Tori, has participated, therefore we were involved. In 2040, we could have a resolution of 20 micron per voxel and ultimately a resolution of 2.26 micron per voxel with the HIP-CT. I'm going to show you the scan of a lady, 87 years old, with a stent in the LAD, and we will start by the volume rendering. So that's the volume rendering. Now I'm going to remove the fat and see not only the artery, but also the vein. And you could see the vein, the artery, the secondary, tertiary, quaternary, and something I've never realized is that the fat can lift away the coronary artery. I always think that the pre-arterial and arterial was in the myocardium, but they are in the fat, compressed.
We are painfully aware of that.
Yeah, you, I'm not. That's what I learned right now, because that fat must have cross-stroke on vasospastic things and many other things. Now, I continue because you could go also to the valve and the myocardium. And when you see something black in the myocardium, is because you have ischemia. And you will see black is the scar tissue. So look at all, it's unbelievable.
Yeah, it's impressive.
Okay, let's go to the myocardium. If I stop at a certain moment here, it's because this is ischemic tissue. And a little bit further, you will see the scar tissue completely black. Looks empty, but it's completely black. Now you go to the valve. You have seen the chordae. We will come back to give you a chance to look again. So this is very spectacular. And then this is the stent of the lady with the calcium. This is the right coronary artery. This is one cross-section of the right coronary artery. You don't get this picture with IVUS or with OCT. You see the adipose tissue, the media, and if I zoom on this region with 2.26 micron, you see calcium speculated, you see the media and the vasa vasorum. Now it's time to conclude, but the question that I have with this kind of image, or what is also on the horizon, the intravascular micro-optical coherence tomography, where you see the cap, where you see the crystal of cholesterol. For many years, we said it's an artifact post-mortem. The necrotic core, and you even see the leukocyte tethered to the endothelium. So the question is, will the non-invasive imaging ever supersede intravascular imaging, or at least compete with it? Now, it's time to conclude and to tell you the truth, all the truth but the truth, okay? I misled the audience only on this last topic, and I must confess. And I confess this is a post-mortem art. It is in gluteal aid. And we had to go to Grenoble to use the synchrotron to accelerate the photon, and the container with the heart was 177 meters from the cyclotron, and the camera was, again, 2.5 to 30 meters per second. And instead of rotating the beam, we have to rotate the heart. But I will tell you, in 2000 in Amsterdam at the ESC, I had the Grunzig lectures. And I was showing our first ABT. At that time, it was electron beam tomography. And we are a quarter of a century behind, and look what we have. So I think at some point, we will use that, certainly for anatomy and post-mortem. You don't have to cut the heart. You have all the information. So time to conclude. This is what I always said to the fellows in the department. If the future is unrealistic, fortunately, it will remain the future. If the future is realistic, sadly enough, it will soon become the past. Thank you.
We have had many brilliant lectures already at this meeting, but I think, like last year, Patrick, I've learned more from yours than from anyone else's. Thank you for sharing your perspectives and insights on an area of cardiovascular care that we surgeons are new to, but we've brought it forward in the program because we believe that this will impact all cardiovascular patients and all cardiovascular care providers, including coronary surgeons. Thank you.
Yeah. The next speaker is William Nicholson, and he will speak about IFR, FFR, IVUS, and OCT, what I do with my catheter and what it means.
Well, thank you again for having me, and it was a fantastic talk. It really is exciting. I think, we're always, resistant as cardiologists to give up invasive angiography, but the day's coming, and I think those images are just spectacular. But I'm going to go through what we use our current imaging and physiology to guide us with, sort of the background on why it is, show you some of the basics and maybe a case example. But, we know from Courage that cardiologists in general are terrible at angiography and terrible at interpreting it. Like they overestimate lesions, they underestimate lesions. And if you just go by their kind of feeling of what should be fixed and not fixed based on an angiogram that often doesn't have optimal imaging and angles to see, we're terrible at it. And, so basically that's why Courage is negative, is because by angiography alone, we don't do any better than medical therapy picking lesions to fix. When we do this, what we have incorporated into this is physiology. And so physiology is a complex set of things that you can measure in the cath lab. Some have pretty clear, guidance as to what we should do with it. Some of them are a little bit more fuzzy still with IMR and things like that, but you can measure basically the epicardial flow stenosis by FFR, and so that's a fractional flow reserve. You basically are measuring the pressure upstream at the aorta, measuring the pressure downstream after the lesion. You give maximum hyperemia with adenosine, and you're looking for a drop. When I was a fellow, we wanted to drop a 0.75, but I think that was not allowing us to do enough cases, so they raised it up to 0.8. You have to give either systemic or intracoronary adenosine to do this, and so through the years, they've come up with different measurements that you can make with basically mitigating the need to give hyperemia, so it makes the interpretation a lot quicker and easier. IFR was the first one with that. RFR, DFR, each of the companies have kind of come up with their own proprietary way of measuring this in a diastolic period to get the kind of surrogate of the FFR, so you don't actually have to give hyperemia anymore, and so you can just measure the numbers. It's a different number. It's 0.8 is a drop, so a 20% drop in pressure for FFR. It's 0.11, so about a 10% drop is positive in IFR. And so when you use this, you guys know FAME and FAME2. If you use FFR guidance versus angiographic guidance, there's clearly superiority to doing that. So when you take those lesions out of play, so anytime you don't intervene on a lesion, you decrease target vessel revascularization, you decrease periprocedural events. And so if you can defer on a lesion, you're going to do better. And so that's why FAME was positive, as you deferred on lesions. FAME2 was reassuring of the fact that basically if they were positive physiologically, could we do those with medical therapy, or does actually intervention work at some point? So finally we have something that shows that intervening does make a difference. So if you don't fix the lesions that are hemodynamically significant, they do have problems, they do get worse, they do have events. That trial was stopped early because of that. And so if you look at syntax, and we have the leader of that here in the crowd, this is really the big difference between syntax and syntax 2. There's a number of different differences, but in syntax 2, the biggest thing that I think you take away from this, or one of the more reassuring things that I've taken away from this, is we deferred on almost a third of the lesions in the trial. So we came to the angiogram, said those are positive, those need to be fixed, and then you had to FFR them to determine, do they really need to be fixed? And a third of them aren't positive, and so you don't intervene on those. And so what does that do? That takes you to a significant number of patients that have less than 3-vessel disease, so they get a different set of interventions done. And you can say, well, if you thought this was significant going into it and I didn't fix it, how do these people do over time? And this is really powerful. So like if you look at this, of the 262 lesions that they deferred on, so they were lesions that you walked in, thought I should fix, decided by physiology not to fix, how many of those went on to have an event over the next 3 years? And only 6 out of 260 of those. So it's a good metric. So for me, if there's a lesion that I'm questionable about, if I have an FFR positive lesion on that, you go ahead and fix it. But if it's negative, you're very reassured that if you've done the test right, and obviously there's some human variability with that as well, but if you've done it right, medical therapy works, and so we're safe to defer on those. And I think that's why we're seeing better results. So we use physiology to determine what we should fix. We use imaging to optimize how we fix it. And so this is, I always say this, if somebody came up with a new stent that decreased mortality by 50%, everybody would switch to it, right? So But you have that. So imaging already decreases mortality by about 50%. And in the States, it's still only about 12 to 15% of all cases are imaged, which is ridiculous. We image nearly 100% at Emory. But what you're looking for is you have two different imaging modalities. You can do IVUS or you can do OCT. Both are great. They're not the level of what we just saw in the past presentation. But if you meet these metrics, let me go back to this. If you meet these metrics, so if you do these things when you're IVUSing and you don't have an edge dissection, you've opposed the stent well, you've expanded to 80% of the MSA, which is a minimal stent area or maximal stent area, so that's how big the stent should be. So if you get to 80% of that, you decrease mortality in these patients by basically 50%. So if you reach those criteria, and it's been shown over and over now, that we have really powerful effects if you're doing this. And so you just saw some spectacular images by Dr. Soroy's talk, but if you look, what we're looking at is we're looking at calcium. So calcium, you probably don't need to know all this as a surgeon, but what we're looking at is you can have thin calcium, which basically is this ring on IVUS, and you can see past it a little bit. You can see these reverberations. When you have thicker calcium, like you have over here, you don't see anything behind it, so we know that's thick calcium. You can only tell that kind of, as a surrogate with IVUS. With OCT, you can actually trace it out. So I'll show you some pictures, but you'll be able to see the actual calcium. We use the calcium, and we have these scores that we use, and we do use them to guide us with when you do need to modify the calcium prior to PCI and stenting. And so this is Kiko Moran at Columbia has come up with this. But basically a set of different scores, smaller vessel, which we consider anything less than 3.5 to be small. Nodules are bare. We still don't know what to do with those, but concentric calcium of 360 or 270 degrees of calcium for at least 5 millimeters in length. All of those are predictors that you're going to need to do something prior to stenting. And so when we do this, that's what we're looking for. This just shows you some nice examples of how you can trace the calcium. So if you have a calcified plaque, you see this kind of delineated border. So if you can take a pencil and trace it out, that's calcium. And when you get lipid, you kind of get a smudging effect where you stop being able to see the media. So you see the media coming around here, but you can't see past it, so it's sort of smudged out. That's lipid. If you see plaque inside the vessel, but you can still kind of see the media, like you can here, this is fibrotic. And then it's sort of the same thing that you're going to see on IVUS for each of those. When we do these cases, we're looking, I'm going to skip this one. But the other place that imaging is essential is in-stent restenosis, and in-stent restenosis still accounts for about 13 to 15% of the cases in the U.S. It's about 1 million cases done in the United States every year, so it's about 100,000 cases of in-stent restenosis. You cannot fix this or treat it properly without imaging, so it's absolutely essential. And so when you're doing the imaging, you're looking for one of two things. Either it's a patient problem, it's a you problem, or it's a doctor problem, it's a me problem. And so if the stent is underexpanded or it's undersized, that's me, okay? If you've come back with neointimal hyperplasia or neoatherosclerosis inside a well-placed stent, that's on you. The vast majority of it is the doctor, okay? So most of what we see as ISR is somebody did a shoddy job of when they did the initial stenting. They didn't prep the vessel, they didn't size the vessel, they didn't use IVUS-guided imaging or OCT-guided imaging to optimize it, and now we're stuck with trying to deal with it. And so that's going to guide our therapy then afterwards of how we're going to reapproach it. So do I need to debulk the lesion? Do I need to modify the calcium? Is it just enlarging the stent? And so all this is guided by image-guided therapy. And so I'm going to show you, this is in a complex coronary trial. Again, we see it again. So this is out of Korea. If you look at patients that have complex disease, meaning left main, true bifurcation disease, CTOs, long lesions, if you don't image those patients, again, you're seeing mortality differences. So it's almost a double difference in every clinically driven metric to assess the outcomes. So how much time do we have? Do we have time to show a quick case? Seconds. Yeah, I'll show you a quick case just here. This is a patient, again, has a proximal LAD lesion, had FFR of all 3 vessels. There was some concern that the right needed to be treated due to this proximal lesion. The right was negative. The CIRC, the IFR, or the FFR2, because somebody thought there was osteal disease. The CIRC when there's moderate disease, it's almost always negative on FFR. The LAD, when there's moderate disease, is almost always positive on FFR. And that's just because of the myocardium that it subtends. And so the IFR, the LAD was 0.86. Patient declined CABG because he was had a good psychiatric evaluation. So I was just kidding you guys. So we rotabladed it to start out with atherectomy because we couldn't image because the catheter wouldn't pass through. And imaging-wise, I just want to show you what we're looking for, but we're looking for these cracks in the calcium. So we're looking to see the calcium is broken. You can see this one's still concentric. But you get some reverberation around this on the outside. It tells you that you've modified the calcium. So we did IVL on it, and I'm just going to show you this one. I'm going to skip it to the part that's interesting. But if you look here, so you see these beautiful cracks that you get right here. So these breaks in the calcium is what we're looking to see. So you see the clear break in the calcium, clear break in the calcium there. So we've modified that now. Now that will give with our stent, and so. Stent was placed, post-dilated, optimized, reassessed by IBIS, and you get a really optimal result. So everything can be done that we need to do. It is just done very poorly in the States. I think our lack of imaging is why bioresorbable stents didn't make it in the States. We just have done a really poor job of it, and I think there's such heterogeneity in the quality of the work. But I think if imaging is incorporated and used to act on what you're doing, I think you can get optimal results. So, thank you.
Bill, your comment about heterogeneity in practice is the reason that we exist here in this society, the International Society for Coronary Artery Surgery. We have exactly the same sorts of problem, a tremendous heterogeneity in practice, not just between countries, but even within cities and even within faculties. So we're all striving to promulgate those practices that we know improve outcomes for patients.
Absolutely.
Thank you.
Thank you.
Thank you. Please. Okay. Mario.
Dr. Gaudino is our next speaker. He needs no introduction. The most prolific researcher and thinker in coronary surgery presently. Mario is going to tell us about FFR and its role as a gatekeeper for PCI and as a gatekeeper for CABG. Dr. Gaudino.
Thank you, John. Thank you to the organizing committee for the privilege of the podium, and my task is to discuss why FFR is a useful gatekeeper for PCI, not for CABG. I would propose to slightly modify the title of this talk. I think the real question is why FFR is a useful gatekeeper for patients with low atherosclerotic burden. Those are the patients that are treated by PCI. They are not the patients that we treat by coronary artery bypass surgery. So let's start by asking ourselves, how did we even get here? Well, we got here for this study that Bill presented before me. This is the FAME trial, Lancet 2015, 1,000 patients randomized to receive FFR-guided PCI or angiography-guided PCI. Now, it's interesting to know that people think FAME was a positive trial. FAME was not a positive trial. FAME was a neutral trial. At the end of the 5 years, there was no difference in MACE between the two strategies. However, you can see in those curves how there is a very clear reduction in the periprocedural risk by using FFR. Over the course of the 5 years, the angiography-guided group did not catch up with the other, and but there was a reduction of the initial effect, so the statistical significance was lost after the second year. In any case, that was the evidence that the use of FFR improved the periprocedural outcome of PCI. Other study, smaller study, generally showed even a benefit, a clinical benefit for FFR-guided PCI. They were generally smaller study. Most of them were non-randomized. I think the benefit in terms of MACE for a technique that leads to least complete revascularization is mostly due to confounder in non-randomized study. What about FFR for CABG? Well, we don't have a ton of evidence. We have two small randomized studies. This is Fargo, was published in JACC a few years ago. There were less than 100 patients who were randomized to receive FFR-guided CAB versus angiography-guided CABG. In the FFR-guided CABG, there were less graft, less lesion bypassed, but there was no difference in patency between the two strategies. Similar result in the Graffiti trial, European trial. Those are small trials. Graffiti was less than 200 patients. There were a lot of issues with those trials in terms of compliance or loss to follow-up, so not really conclusive, but overall, not a great evidence of any benefit for FFR-based CABG. With David Glineur, we performed a non-comparative FFR-CABG study. We were trying to identify the cutoff for graft occlusion or graft patency when using the ITA. We identified this cutoff at 0.78 with important difference by coronary territory. In the right coronary system, the FFR cutoff was 0.72. In general, putting everything together, the benefit, the patency benefit for FFR-used CABG is strictly related to the number of arterial grafts used. In other words, you can see a benefit, which is an artificial benefit, by the way, of using FFR only for surgeon or in patient to receive arterial graft. FFR does not make the patency rate of arterial graft better. It just provides information for a better indication to the use of arterial graft. So it's an artificial inflation of the patency rate. How does FFR affect the comparison between PCI and CABG? Well, we don't have a trial that tests that specifically, but we can look at syntax and FAME, right? When FAME was designed, I remember the ideas was to do syntax using FFR. And so how do the two compare? Well, the overall result doesn't really change. At the end of the first year, there is a 6% benefit in terms of MACE for surgery. But if you look at the initial part of the curve, something has changed. There is, in syntax, since very early, there was a separation of the curve and higher risk for PCI. That was not the case in FAME. So again, the use of FFR does increase procedural safety of PCI. And the reason for that is that the result of PCI are mostly dependent in terms of safety by the number of lesions that are stented. This is an interesting large registry study that is looking at the effect of clinical risk factor versus procedural risk factor on the number of outcomes. And the procedural risk factor are mostly related to the number of lesions treated, the number of stents deployed. And you can see the procedural risk factor are in red, and it's obvious that for outcomes such as MI and repeated revascularization, the procedural risk factor are more important than clinical risk factor after PCI. So there is no doubt that the early outcome of PCI are related to the number of lesions that are treated, and the less lesion you treat, the better your early result. This is not the case for CABG. This is the STS risk calculator. We are all familiar with that. The number of graft is not even mentioned. The number of diseased vessels are only a marginal impact on our outcome. So the mechanism of PCI and CABG are completely different. The risk associated with the two procedures is independent by the number of vessels grafted in CABG. This is not the case of PCI. This is the rationale why FFR role is very different for the two interventions. And in fact, and this is a slide that I've seen John presenting many times, we know that the result of surgery, this is from syntax and from Sabatin meta-analysis, are essentially constant across the spectrum of coronary complexity. This is not the case for PCI, and this is why in cases at high coronary complexity, CABG generally does better than a PCI. The other important issue is that the patient enrolled in PCI trial and patient enrolled in CABG trial are very different. Bill has shown that, but In general, patients who receive the PCI have lower atherosclerotic burden. There is the progression of disease is much less aggressive. Look at this in this registry. In the first year, the FFR value in untreated lesion was essentially unchanged. It went from 0.86 to 0.83. In the Fargo trial, that was not the case. It went from 0.89 to 0.79. So there is a much more aggressive progression of coronary disease in patients who are referred for CABG. Deferring lesion for patients undergoing CABG is not a good idea. Those patients will be back for those lesions. So what's the role of FFR for CABG? Well, we also have to keep in mind what Torsten has shown us yesterday morning. The effect of CABG is mainly due not on the treatment of functionally significant stenosis, but because of the prevention of ischemic episodes that are related to stenosis that are not functionally significant at the moment of the index operation. And remember, in patients with coronary artery disease, it's not the number of flow-limiting stenosis that determine prognosis, it's the overall atherosclerotic burden. In general, the risk of cardiac event at the level of the individual lesion is clearly higher for lesions that are hemodynamically significant, but because the number of non-hemodynamically significant stenosis is so much higher than the number of significant stenosis, the overall number of events is higher based on lesions that are not hemodynamically significant and become unstable. And there are large registry data that show that, again, it's not the number of functionally significant stenosis that determines prognosis, but is the overall atherosclerotic burden. And the key benefit of CABG is bypassing lesions who are not hemodynamically significant at the time of the index operation. This is a large registry study from North European showing that at high level of calcium score, there is no difference in the prognostic impact of hemodynamically significant versus hemodynamically non-significant stenosis. And then remember, the key benefit of CABG is because we bypass the proximal part of the coronary artery. This is a slide that shows you the location of unstable plaque and the location of the distal anastomosis of our graft. And we are always constantly distal to the location of unstable plaques. There are autopsy studies that show that unstable plaques are generally located in the first 3 millimeters of coronary artery. Our grafts are many centimeters below those lesions. So those are my conclusions. PCI results are dependent on disease complexity and number of vessels revascularized. CABG results are not. CABG bypasses the entirety of the proximal coronary tree where most plaque rupture occur and protect against both hemodynamically significant and non-significant plaque. Patients included in PCI and CABG study are different. So putting all together, in CABG patients, yes, you can use FFR to decide what conduit you want to use, but never use FFR to decide what vessel you want to revascularize. Thank you.
Our last speaker of today is completing the series of imaging available in cardiac surgery and for us to guide revascularization with a cardiac MRI in assessing viability. Francisco Alpendurada, please.
Thank you. Okay, perfect. Thank you very much for a kind invitation. Good morning, everyone. I don't know if we have a pointer. Yeah. We have a pointer here. Perfect. So, yeah, you probably know that MRI can produce very nice images of the heart and provide very important information about anatomy and function. But the big breakthrough for this technique is contrast imaging and the ability to look for irreversible injury. And with this pioneering work from Northwestern University, showing excellent correlation between GAD enhancement and the presence of myocardial infarction, as you can see here. So in conclusion, the authors showed that contrast MRI distinguishes between reversible and irreversible ischemic injury independent of wall motion and infarct size. So they started trying to think about other potential applications in the clinical setting, and that comes to viability. And the following year, they published this seminal work assessing contrast imaging and reversible dysfunction, and they found out that patients with severe dysfunction, there is an inverse relationship between the transmurality of the infarction and the likelihood of recovery. I think it's easier if I present a couple of examples. So this is a patient with extensive dysfunction and extensive near transmural infarction in the matching areas. The interventionalists decided, we should try and open the arteries, but then you can see that there is not much of a difference pre and post revascularization. So this case, you have significant LV dysfunction, but minimal scar, minimal infarction, and this patient was revascularized, and you can see significant improvement in LV function. So these are two extreme but prime examples supporting the concept of viability. It's a very simple method. There is usually no need for stress, and that's why it tends to be quite suited for like the old frail patient, the inpatient that is still not entirely stable, and you prefer not to push it too much with pharmacological, physiological stress. The thing that we have to have into account is that this is actually a continuous variable for categorical decisions. Is this viable, non-viable? Should we revascularize or not? So we're just going back here to the same graph. And if we see patients with severe dysfunctional segments, if I have transmurality between 75 and 100%, likelihood of recovery is 0. Between 50 and 75 is around 10%. And usually that's why we call these segments non-viable. If it's less than 50%, usually we call them viable and hibernating. But again, there is a sliding scale. And if I don't have any infarct, the likelihood of recovery is over 80%, but then it goes down to around 50% if I have transmurality between 25 and 50, which is sort of a toss of a coin, which is actually not that helpful in these intermediate categories. Some centers advocate complementing with low-dose dobutamine that has a better positive predictive value than GAD enhancement, which has a very strong negative predictive value. But it's time-consuming, and we compare with perfusion imaging, where perfusion defects show areas of myocardial ischemia. So this is a patient with significant triple vessel disease, and you can see extensive ischemia only sparing the basal anterior wall and mid-apical anterior lateral walls. And usually you put everything together, and just looking at that basal perfusion slice, we can compare with the CINES, we can compare with the late GAD images. We can say that this myocardium is viable, and there is a lot of ischemia, particularly in the RCA, less so in the circumflex and also LAD. And combining together with function, the lateral wall is contracting well, so the LCX is viable and ischemic. The RCA is viable, ischemic and hibernating, and also happens here in part of the LAD territory here basally. So this is important information that we can provide combining perfusion and viability. We all know that perfusion by MRI is well established, and one of the better techniques in this meta-analysis was the best alongside PET. But taking it a step further, this is our landmark MR-informed trial, where patients with a high likelihood of coronary artery disease were randomized to MRI-guided strategies. So if I had significant ischemia, the patient would be revascularized. The other arm was the state-of-the-art FFR arm, so the patient will have FFR. If it was positive, the patient will be revascularized. So you can see here that the MRI arm, you have much less angiographies and less revascularization, but at the end of the day, looking at the outcomes, they are quite similar between MRI and FFR. So supporting that we should, that MRI-guided management can be as feasible as a FFR strategy. Okay. And actually can provide additional information. So for instance, this is a patient with previous PCI 12AD, CIRC and RCA. There's a small infarct here in the anteroseptal wall, but more importantly, you have ischemia in the anterior wall corresponding to a diagonal branch. I haven't mentioned that the resolution of perfusion sequences is around 2.5 millimeters or less, and we actually can go down to 1.5 millimeters, like in the current sequence that we are using. And also we can use perfusion maps as well to quantify myocardial blood flow. The patient came back around 1 year later with worsening and refractory angina. The perfusion visually, it looked exactly the same, so there was no suggestion of new intrastent restenosis. But if you look at the perfusion maps, you can see a drop in signal showing reduced global myocardial stress blood flow, showing that there is additional increasing microvascular component, and obviously prompts to optimization of a specific medical therapy. So onto a more contentious topic. There are a lot of single-center observational studies that suggest that, like this one from Bernard Gerber in Belgium, that if you have viability, revasc will do better. If you don't have any viability, you don't have much difference between revasc and medical treatment. But on the other hand, we have randomized controlled trials. This is the STITCH trial that was released more or less at the same time. And even though that viability predicted mortality on multivariate analysis, there was no such association. I listed some possible explanations why we have a gap between results, but we know that we have more recent randomized controlled trials like ischemia and REVIVE trial that have similar negative messages, and that's why the use of viability testing is being downgraded in guidelines. But interestingly, we're still getting a lot of referrals for viability testing, and probably it's because behind these lines of just binary lines, hides a more complex story, and all the patients are different, complex, unique, and that's why I still use viability ischemia imaging for individual decision making. And MRI can provide additional information beyond ischemia and viability. So for instance, the scene is not working, but this is a pseudoaneurysm due to a rupture of the interventricular septum, and the patient's life is hanging on by a thread due to remaining RV tissue, and actually working as effective fenestrated VST with a huge shunt and pulmonary hypertension and huge pericardial effusion. And the surgeons and the ITU team did a brilliant work to keep this patient alive. This is a patient that we scanned yesterday, apical infarct. The contrast echo, so there's a low likelihood of a thrombus, probably some false cordia, but let's have an MRI, and the contrast images convincingly say that this is a thrombus. We can also look for a pericarditis, in this case due to a transmural infarction, also with microvascular obstruction that has incremental value for adverse remodeling and outcomes. And finally, as well as an example, this technique is very good to pick up right ventricular myocardial infarctions and also derived RVF. They have shown to have strong independent prognostic power in coronary artery disease. So in conclusion, viability is a simple method that can help decide planned revascularization, and you tend to use it when you have severe stenosis or occlusion, and most suited for old, frail inpatients. Perfusion, I think it's a complementary tool, particularly when you have stenosis of unclear significance, and also for evaluation of vaginal chest pain. And all the data we have has strong prognostic value, but randomized controlled trials are unconvincing. So that's why I think we are moving more and more to a tailored approach for individual decision making. Thank you very much.
Francisco, I have a question for you. There's a lot of debate even yesterday in the heart failure session about viability, non-viability. I have a picture in my mind, but I don't know if it's completely off. I believe that viable or not viable is telling me, I have this picture of a garden, okay? If the patient has a non-viable myocardium, most likely if you have good conduit or good target and you can bypass it, most likely with your bypasses, you're gonna regrow some grass, maybe not flower. If you have viability, once you bring new blood, once you revascularize, you can really regain the full garden with the flowers and all of that. And this is probably the game between viable or not viable, telling us how much you're going to regain after the surgery, how much help do you need to pass this patient through the surgery, a balloon, an impeller, an advanced support, and if there is more than if there is a sense or not. I just want to know your feedback about this picture. I'm completely wrong, or this is probably...
No, yeah, it's right. And yeah, I think the difficulty is that, yeah, as I mentioned, we just think, shall we revascularize or not? That's usually what the emphasis on the studies. But yeah, patients are very different. They have different risk factors, frailty scores, other pathologies, and also the variables we're talking, viability. Also, it's a continuous variable. Yeah. The more the segments, the more likely you're going to recover. The less scar, the more likely you're going to recover. And the same for ischemia as well. Yeah. So that's why sometimes it can be quite difficult to make like a comment based on like these big trials, compoundly very heterogeneous population. Yeah. And that's why, yeah, the value of the role of MDT meetings, so we can discuss these patients individually to try to take them the best management strategy for them.
Thank you for your excellent presentation. In my own mind, the difference between viability and non-viability becomes irrelevant unless the muscle is completely, fully infarcted. And I think the benefit of revascularization, if there is in that spectrum of viability, is not the immediate benefit, but the protective effect of bypass grafts. So that if these patients get further proximal culprit lesions, they are protected. If you've already impaired viability and you have a subsequent infarct on top of that, then that is certainly going to affect your prognosis. So I think the real difference between them, unless the muscle is completely dead, is the protective effect of bypass grafts.
So I have a slightly different view than Gianluca. He's Italian and he thinks in flowers. I have a Hungarian background and I think in numbers, mathematics. And I think about viability as a fourth dimensional problem. It's not just what the volume of the muscle is that's alive, but it's when you measure it. Time seems to have an impact. And in fact, the same patient may have a viability scan a month after a myocardial infarction and then a year after the myocardial infarction, and we get different percent viable muscle on the reports. So it seems to me that part of the reason why these data have been so conflicting and unclear is that it matters when you measure it, not just how you measure it. Yeah. All that said, thank you for a very interesting presentation and for a great session for all the speakers.